left bundle, Sgarbossa Criteria, and AMIs on this episode of the EM Unplugged podcast. Let's go. Hey everybody, thanks for joining us on the EM Unplugged podcast. I'm Charlie Swearingen.
I am Gregory Carr.
There he is. So today we're going to cover a bit of Sgarbossa Criteria, the myths, the legend, the possibilities, the accuracy, its inability to fail almost. It seems that's what we're going to do today. This particular video had 13,000 views in just a week or two, so I think this is a good topic. Greg, this is what you wanted to talk about today for sure, and rightly so. It looks like there's a lot of good stuff to go over. What are your thoughts? Why this one?
One of the things I hear a lot is people say that Sgarbossa Criteria is unreliable, and so much to the point that paramedic programs don't teach it. Paramedics aren't allowed to use it in many places. And while technically it's correct, the original Sgarbossa Criteria did have one of the criterion who were not reliable. With Smith's modification, the sensitivity and specificity has gone through the roof, so much so it's 80% specific, 80% sensitive and 99% specific. So this is a very useful tool that you can discern things from an EKG. No labs, no needles, nothing like that. And it is absolutely a tool that should be in every paramedic's toolbox, and it should become common parlance. The major obstacle is that there seems to be some difficulty understanding some of the terminology around it. The concept itself is not very complicated, and I think that's something that you and I can break down and show to the world, and people will dig it.
Sweet. Let's jump into that then. Let's quit beating around the bush. This is good. This is a great topic. This is one of those things that you might study this for critical care exams. That's where I was first exposed to it. And I'm like, wait, what is this? And because I remember in early 2000, yeah, 2000 or 2001, I think I was in paramedic school going over cardiology, and I remember that the new rule of the left bundle branch block, there's a new evidence of left bundle branch block, you can't really call it a STEMI, and so we couldn't see it. And I think these guys at the time were in med school, or they were in med school or residency like in the early mid-90s, and they're like, F y'all, we're about to figure this out. We're about to figure out a pattern, and that was Senor Sgarbossa and company. So talk to us quickly about the reliability. So why should anybody watching this right now give a crap?
So one of the biggest misunderstandings around the left bundle branch block is that there's no reliable way to identify the presence of an MI. And for the purposes of this discussion, we're talking about transmural MIs, right? So STEMI, what people commonly call a STEMI, or the new common parlance is becoming OMI, right? Occlusion myocardial infarction. The thing about it is, the wide complex that is present in a left bundle branch block is not necessarily the problem. That's just how we identify it. What throws people off is there's what's called discordance. And this kind of ties into one of the things that's difficult for some people to understand. Discordance is simply a disagreement, something going opposite ways. So in this context, when they say discordance, they're talking about the QRS complex going one way and the T wave going another, when you say discordant in this category of things we're talking about. Now, that is normal in a left bundle branch block, which throws everybody off because of that huge misconception that every T wave inversion represents ischemia. The T waves in a left bundle branch block are not, in fact, inverted. It is normal for the QRS to go one way and the T wave to go another way in a left bundle branch block. And this messes people up because we like to measure from the J point. We look for ST elevation. It fumbles with our normal look at morphology. And we are able to get past that by understanding some of the pathophysiology of what's going on, and reliably, 8 times out of 10, identify an MI, and 99 times out of 100 say this person's not having an MI because this is not here. And that's just a huge thing. It's one of the reasons I wanted to talk about it today.
Can you put that up on the screen? I know you have
absolutely
a website.
Yeah, let's get into some pictures, because I am a picture guy for sure. I've got some slides here I'm gonna show, and Charlie's got some ECG Hero as well. If I can get to it here, where am I having so much trouble looking to go? Yep, here it is. And I apologize for that. So let's just have a look at, so this is the standard picture everybody sees. I'm going to click slideshow on this so everybody can see it. So this is the standard picture everybody sees. You look at the appropriate example of Sgarbossa criteria here, that when it's positive, you will have a QRS complex going one way and a T wave going the same way, right? Let's look at a normal left bundle branch block here. This is actually from a presentation I do called Never Mind STEMI Imposters. And it's for that reason. So here is a normal.
It's so last season.
It really is.
Imposter.
Yes, absolutely. Yeah. So this is a normal progression of the QRS and the T wave and what you would see in a left bundle branch block. So here we have a QRS complex. It's obviously wide. It's got the quote unquote rabbit ears, the RSR prime wave.
Mm-hmm.
And then the T wave goes the opposite way. This is not indicative of ischemia when we're looking at a left bundle branch block at all. This is how it's quote unquote supposed to go in the presence of the left bundle, right? So it's normal to see a positive QRS and a negative T wave. And it's normal to see a negative QRS and a positive T wave, depending on which lead we're looking at and stuff like that. That's the normal, right? That's the go-to. And it's normal. You see this small bit of elevation right here. So let's say we saw this in B1, B2, B3. That's normal. And that is the crux of the whole argument, the whole problem with why they say Sgarbossa's criteria is unreliable. The average person, to include many physicians, cannot differentiate. But we're going to show you today it's actually really simple to do. Okay. So let's look at the positive Sgarbossa's criteria and mentally compare it to this so I can show you guys what I'm talking about. So going back to the slide we looked at a moment ago.
Can I bring up one thing? Because this was like one of those things that always would trick me up is that friggin' word concordance, discordance, or concordance, right? It's just a churched up way to describe a feature. And I get it that cardiologists and physicians in general have earned the right to be a doctor at a doctor level in medicine, of course. And but sometimes we get lost in nomenclature. We're really proud sometimes of our nomenclature in medicine. Yeah. And so for me, the whole idea of what is dis or what is con, right? And in the end, there's two players. And I know you're about to show this, but just so that's clear so we don't lose people, because I'm a knucklehead. And in the end, we're talking about the two features is the ST segment. What it's doing, is it up or down? And then the QRS complex, is it up or down, essentially, so positive or negative. And that is what is either the same or different, and that's discordance versus concordance, right? So if they're the same, it's concordant. If they're going in opposite directions, and it doesn't matter if one's up or one's down, if they're going in opposite directions, that is discordance. So I think our plan is to talk simply and not use as much of those terms, but if people hear it, discordance, they're going the ST segment and the QRS complex are going in opposite directions. Concordance, they're both going up or they're both going down.
It's all about the prefix con and dis, right? So if you meet someone that you like very much and you two have an intimate encounter, that is described as consensual, right? So you're going in the same direction. And if you're arguing with someone, you're having discord, right? So just like the app Discord, it's a place where I go to argue with people. So the con means that they're going the same way. They're in the same general direction, whereas the discord means that they're facing opposite ways, so to speak, discord. So if Charlie and I, we have discord on what the best bourbon is, right? Because we may not necessarily agree on that. We're going in opposite directions. So that's all that really means. So when we throw these polysyllabic terms, these $10 words at it, it's great to be able to say what you want to describe it. But at the end of the day, con is the same direction as the QRS complex to the T wave. And dis is the opposite direction, right? That's all we're talking about. So when there are concordant, if you have concordant ST segment elevation, the QRS complex and the ST elevation are going in the same direction. And if you have discordant anything, the QRS complex and the ST segment are going in the opposite direction. And so discordant ST segment elevation is the norm in the left bundle branch block. And that's why so many cath labs have been alerted to a STEMI that's not there. But concordant ST segment elevation should not be ignored. I don't care if it's a wide complex rhythm or not, right? The heart is not necessarily respective of your ECG skills when it decides to tear off a piece of plaque and throw a hunk of fibrin, right? And it's a shame that we spend so much time, and we are all, our whole field, we are so talented at interpreting the morphology and divining so much information from squiggly lines, and we get hung up on those words. So I'm not necessarily a big fan of those two words, because I think it's, here in the South, we say it's a nickel holding up 50 cents, right?
Yeah.
It's a small thing holding up a much greater concept. And the greater concept, we are perfectly capable of understanding, but we threw a monkey wrench in the gears with the terminology.
Yeah, no, totally get it. I didn't mean to derail you.
I dig it.
Not that's possible for you.
Yeah. No, yeah, I know that guy never goes off on tangents. Not
Oh,
Greg.
that's funny. Continue.
All right. So one of the biggest things I try to tell people, and I'm just going to pull up an EKG here now. You know what? I'm going to pull up a paced rhythm just to spice it up, because when you talk about putting pacing pads on the outside of a chest and a left bundle branch block, morphology wise, Sgarbossa still applies, right? So there, of course, are subtle differences between a left bundle branch block and a paced rhythm. But when we talk about Sgarbossa, they're the same. They're essentially the same for what we're looking for, right? So what I would love people to focus on are the first two out of the three criteria of Sgarbossa, right? You know what? Let me back out of this and let's just review that, because we go in circles a little bit. So let's look at these three things, okay? So these three things, we have concordant ST segment elevation, or, and I'm going to move this so you guys can see it. You can have concordant ST segment depression in V1, V2, or V3, meaning that the ST segment's elevation or depression is going in the same direction as the QRS complex. Or you can have this third one up here that is labeled with the big arrow, unreliable. We're going to talk about it in a minute, but all I want to focus on right now is concordant ST segment elevation and concordant ST segment depression. Let me show you why these are by far the two most important things. Let's go back to that paced rhythm and have a look at that together. So again, same as the left bundle branch block in terms of what we're looking for. So if you look at this EKG, everyone who looks at it, you're going to notice some things. For one, it's ugly, right? These are what we call the spicy squiggles, right?
Mm-hmm.
It's a little scary to look at. We see pacer spikes. There's some confounding data here. There's some things we need to worry about. But if we took all that out and we took a second, we took a deep breath and said, what exactly do I see? One of the first things you would notice is you have ST segment elevation in lead 1 and AVL, don't you?
Mm-hmm.
Right? Nothing too fancy. Yeah, it's a wide complex. It's surely ugly, but here's our QRS complex, and then huge amounts of ST segment elevation in both 1 and AVL. So right here,
Yeah,
let's take a second
just
and
make sure
pause.
everybody's before you keep going. Put your cursor over the T wave.
Okay, all right. So here's our T wave,
Yep.
right? This is our T wave. This is our QRS complex. And as you can see, it does not return to baseline.
Right.
Same thing in
Beautiful.
lead 1. We're actually experiencing a T wave and elevation almost as high as the QRS complex itself.
Love
So
it.
this is what we call like a massive STEMI, right? Can you see my cursor?
Yes, sir.
Okay, I just wanted to make sure. Yeah, you never know how this stuff goes, right?
Right.
So based off the rules we know about a STEMI, right off the top of our head, if we have elevation in 1 and AVL, Charlie, what do we have?
1 and AV. What was the question? Sorry, I was thinking about the next segment.
Sorry. That's okay. No, I understand. You
Re-ask.
So if I pull up an EKG, any EKG with a narrow complex, everything's good except this, and I see ST segment elevation in 1 and AVL, what have I just found?
High lateral.
I found a high lateral MI. So one of the ways we confirm a high lateral MI is we want to look and see if there's any ST segment depression anywhere. Where would we expect to see that?
Opposite of high lateral, so inferior.
Right. Yeah, so we would look for the inferior leads. And of course, it doesn't have to be present in all three, and it rarely is. So we look into, we don't necessarily have it, but look right here. We have 3 and AVF, right? We have what amounts to reciprocal depression. It's just in the presence of an ugly wave that happens to be wide complex. So the fact that this is a paced rhythm, or if it were a left bundle branch block, that is irrelevant to the fact that we have ST segment elevation and we have ST segment depression, and we have them in the places that they have to be a STEMI, 2 contiguous leads, right?
Right.
So this high lateral MI is significant, right? It tells us that there is probably a blocked left circumflex artery.
Mm-hmm.
And of course, if we look at the inferior wall of the heart, we do see the ST segment depression that goes along with that, right? That's our peas and carrots. It doesn't matter that there are pacer spikes on this EKG, and it does not matter that this is a wide complex rhythm. And it doesn't matter that the other stuff is moving in a weird and opposite way. If you look over here at V5, look at my cursor, we see our normal function of a paced rhythm or left bundle branch block, because the energy is traveling in very similar ways. We have a negative QRS complex. We have a positive T wave. That's normal. That's what we expect to see. Ugly, yes. Significant, no. But this in 1 and AVL, very significant. It's still an MI. And I always tell people this is worth learning, because if you have a patient who has a left bundle branch block, is more often than not, that's pretty significant, right? That means that they have some heart disease, doesn't it? Is there any rule that says if you have a left bundle branch block, or if your heart required a pacemaker, are you more likely to have an MI or less likely to have an MI? I would say you're more likely because you already have some sort of heart disease going on, vast majority of the people. So that's the first part of Sgarbossa I want people to grasp, is get your head out of the concordant and discordant space and all the technical aspects and the $10 words, and say, you know what I got here? I got an ugly STEMI. I got a STEMI and a wide complex rhythm. Wide complex,
Beautiful.
yes, but it's still a STEMI. You know what I mean? It's still one of the three main arteries of the heart that are blocked. And that's your first criteria right there. It's two things that are important, your depression elevation, but that's your first criteria. And it's the most important. And you could flip this around. It will look identical to this in an inferior MI, identical in the fact that there will be elevation in 2-3 in AVF or 3 in AVF. You know how that goes, right? You got to have a pair, not three of a kind.
Right.
And you would have reciprocal depression often enough in 1 in AVL. And those same STEMI rules apply from before, that you don't necessarily have to have reciprocal depression, but the elevation is there. And the thing that makes it relevant, the thing that makes it worth understanding, the thing that makes it confirmable, is that the QRS complex and the T wave are going in the same direction. They're going in the same direct concordance. There's the $10 word that we all struggle with. The QRS complex and the T wave are going in the same direction. That's a STEMI. And that's what I love to get people to understand. And I hope if you're watching this right now, you just had an aha moment. It's still a STEMI. You still need a cath lab. You still need it within 90 minutes. Of course, if you got a pacemaker or a left bundle, you may not have 90 minutes. So this is something that we want to identify.
Yeah.
And go ahead.
Yeah, and I think that's perfect, because there's a couple different ways that people will figure this out, or approach this rather. It's if they have a nasty 12 lead. Okay, so let's say you go through the process, you're looking for stuff. You see this, see segment elevation, but maybe I don't know for sure if that's all right. So you go through the motions and you get to the point where you get to your V1, and that's a wide complex, right? And it, from that J point, there's only one direction. It's basically just like an R or a S wave there. An S wave. I guess that could be a Q, like a Q S wave or whatever, however we term that. But in one, it's wide and it goes down from the J point retrograde. So that is a wide complex. That is a left bundle branch block. That's what it looks like. And so then the next step, what I try to point to people is, okay, if they have the symptoms of heart attack and it's a wide in V1 or any other evidence of left bundle branch block, then go through the motions and look for, the way I normally say it is high fives or low fives, right? So if your ST segment elevation is up, you put one hand up. If your QRS is also up, you put two hands up. That right there, if you tell somebody that you have concordant in X, Y, or Z lead, then that meets criteria. It just has to be in one lead in this case, right? Mm-hmm. Right. Now, more than, of course, there's a little bit more credit to it, but it just has to be in one lead, and that meets criteria. And so the same thing if you have low five, if you have a QRS that's downward and your ST segment is depressed, like we see there in lead 3, that is telling, I think that's where you're going. I hope I didn't just steal any thunder, but like that, boom, that tells you, okay, now we have evidence to support, especially in the face of standard eye symptoms. And of course, if it's female and they have the lower back pain and they have nausea and not really direct, those are the ones to worry about and let the ER docs know. And if you're big badass Billy, then maybe you call and see if they can crack a cath lab open and get ready for you.
And see, you said worry. Worry is so important, because Sgarbossa's criteria does not fail in the classroom or when you're talking about it on a podcast. It fails in the field. Why? Because we worry. We pull up a rhythm. We pull up an EKG like we see on the monitor right now. And we go, that is ugly. That is hideous. I can't make heads or tails of it. We start to panic. And I brought my car keys for this because I have a good analogy I use in lecture. So here's my car keys, right? You watch any horror movie, whenever they're trying to find their car key, when the killer's after them with a chainsaw or a bazooka or whatever he's got, and what do? Right. And that's exactly what we do when someone is pale, cool, clammy, diaphoretic, they're gray, whatever in front of us. and we see this thing that does not readily jump out to us, obviously, because our brain's pre-programmed to say we're looking for a STEMI. And what we want is a beautiful, narrow, complex rhythm with elevation in the right places, like the little charts, the little card that we have.
Right.
And we panic. And it's not that the information was hard to discern. We were in the wrong headspace. We're fumbling for our car keys. And in every horror movie, I just want to reach through the screen and grab the person's keys and go, and that's what we can do
Right.
as paramedics. We take a deep breath and we say, all right, the clock is ticking, but it's not a matter of seconds. It's a matter of minutes. It's an hour and a half. Take a deep breath. All right, what were the rules? I'm gonna stop. I'm gonna pull my, I think it's right brain. I'm gonna pull my right brain out and use my left brain and look at the directions, not the picture now. The picture is ugly, but according to the directions, I have elevation in 1 and AVL. That's my 2 contiguous leads. Let me see, even though I don't have to have it, let me see if I have reciprocal depression. You know what? Sure enough, 3 in AVF. This is exactly where I would expect it to be in a high lateral MI. So if we take that second and take that deep breath, this criteria doesn't fail us. And according to 2015, Myers et al., and guys, we'll include the link to this in the notes, it works 80% of the time to find it and 99% of the time to rule it out, right? So this is even better than what you saw on Anchorman, right? 60% of the time, it works every time.
Right.
That sensitivity and specificity for a test that doesn't require a drop of blood is amazing. That is, and Charlie is the critical care master here. He'll be the one to tell you, you don't get that every day. That's a bonus. So this is not something we should shy away from. We should be quite thankful that we have such a reliable test that is so easy to interpret. One of the biggest problems with Sgarbossa, and before we proceed further, I just want to outline this, is that it's so misunderstood. And we have so many instructors who, one, have maybe don't understand it fully, and two, have not had to use it much in regular life and seen it tested and seen the random things that happen where everything doesn't fit the textbook definition, all that good stuff, that they're not able to accurately and reliably teach it. And it's the same problem with a lot of physicians, including some of my friends who are emergency medicine physicians. And guys, that's fairly important, right? I'm 39 years old. I was a medic in Iraq with guys who are now physicians. They weren't. I was with them through that journey. And we talked, not so much like a mentor to mentee level, but 2 old friends who were in the sandbox together. And I tell this to them and they never explained that to me in medical school. And that may be because those guys didn't know. Now, that's not a slight at anyone. What I'm saying is this is good information that not everybody knows. We have to present it in a respectful manner with the understanding that it just hasn't made it around to everyone yet. So there's nothing new under the sun here necessarily, but there is no reason you can't use this. If you'll take a second and find your car keys, calm down, get over the fact that it's an ugly picture. This stuff is reliable. It works. And I hope so far watching this, you'll say, you know what? That's fairly easy to identify. That's not so bad.
Yeah. No, that's great. That's so important because in the end, like this is one of those topics that I think that is just, it's tough. I first was exposed to it in studying for the FPC back in 2003, Mercy. And in the end, it's very easy, even though it's a difficult thing to recall these rules. Now, it might be difficult in the moment. Like you said, we're worried about everything that's happening, but this is why we practice, right? So the more that you look at these, the easier it gets, and you can begin. I think you made a good point earlier when we're talking about like this is a paced rhythm, but everything still holds true. Like whatever the pacer does, it's what the electricity does after that's important. And so too often, like, oh gosh, vapor lock. I have no idea what XYZ happened with the after something's paced, and in the end you approach it very similarly. And if you can remember these rules, and that's just keeping it real simple, man, you can that 12 lead very easy to find what you were looking for.
And so let's move on to the next one now. And I put you back on the big screen here because you're prettier than me, but I'll do the screen share one more time. And let's talk about the next criteria. So in order to go to that, let me screen share. Let's go back and look at the textbook definition of that really quickly, and then look at it in real life in exercise. All right. So here we are, our next problem that we wanted to identify. And let me move this little window here. Perfect. And I don't know if you guys can see it, but my Zoom thing is in the way and I want it to go away. I think I can get the corner here. Oh, come on. I suck at technology. I am not as cool as I wish I was. V1, V2, and V3. If you look in the lower right-hand corner where my cursor is, ST segment depression in V1, V2, V3. Now, if you're familiar with the posterior MI, or if you've seen any of my videos on that, you'll see that this is something that is indicative of the backside of the heart, obviously posterior, being compromised. And it's because one of the front arteries is blocked, right? So it's either the right coronary artery, 80% of the time, the right coronary artery supplies the posterior side of the heart. 15 to 20% of the time, the left circumflex, or a combination of the left circumflex and the right coronary artery are what supply these, right? What is the reason for saying that? What's the takeaway? When you see an inferior MI, look for posterior MI, because it's 80% chance. It's an 80% chance. That is what's supplying the posterior side of the heart in any given patient. You pull a random person off the street, 8 out of 10 chance that their right coronary artery supplies the backside of their heart. When the right coronary artery is blocked, what do we get? Most of the time we get an inferior MI. So inferiors and posteriors go together like peanut butter and jelly. Keep that in mind. Okay. So let's see it in practice, right? So this, again, one more time before we go to the EKG, we're talking about concordant ST segment depression, and this only counts in V1, V2, or V3 because it represents the backside of the heart. I won't go knee deep into that on this, but I do have videos on posterior MIs. And you know what, Charlie? It might be something for another day that we could cover to talk about the posterior MI in itself, because that's a lost concept. So I have an EKG here that I use for that. Let's put it on the slideshow so it's nice and big where everybody can see it. So here we have a left bundle branch block. It is positive for Sgarbossa. The reason it's positive is, if you'll look, there's a little bit of ST segment depression in V2 for sure. And you look at V3 right here. Okay. Now it does go over into V4, V5, and V6, but remember, that's not necessarily part of the criteria. It's absolutely not part of the defined criteria. And as Charlie said before, we don't necessarily operate on the 2 contiguous leads rule when we're in a left bundle branch block, because we have to take what we can get because we have a limited view. But when we see this ST segment depression, this means that the backside of the heart is infarcted, because EKGs don't work precisely like a picture. They work more like an X-ray, more like a photo negative. If you're old enough to remember, you could hold a negative up to the light before we had digital cameras, and you could see through it and you could flip it around. So if you look where my cursor is, if I could take my fingers and grab the tip of that QRS complex and flip it up, it would be a STEMI, right? And that's exactly what it would be if you were to put electrodes on the patient's back and look at it directly from that angle. It would be a STEMI. This is 100% a posterior MI. Now, what makes this EKG great for an example for Sgarbossa's criteria is that this is a posterior MI in isolation, which you almost never see. Why is it important to identify posterior MI in isolation? Because it means that you don't miss things. It's easy enough to find the inferior MI and a posterior associated with it. That's why I explained those things before. But even in isolation, which is such a rare occurrence, the Sgarbossa-Smith modification still works. It still finds that patient's MI. It still lets you know pads on, appropriate therapies, PCI facility, heparinizing if that's what your agency does, Plavix if that's what your agency does. You don't miss anything. At minimum, you're going to do the aspirin, right? Get that thromboxane out of the way and make it so that we can't grow this clot, if nothing else. And the Sgarbossa-Smith works for that as well. So it's very hard to beat. So just to cover exactly what I'm looking at here, it's much more simple than the last one. ST segment elevation, here's our QRS complex. It is negative, as it should be in this particular lead. That's normal for what we're looking at. And we see the ST segment depression. And one more time, if I could just grab the tip of that QRS and flip it up, it would look like a STEMI. And that's because it is. We're looking at a backward STEMI. We're looking at a photo negative of a STEMI. So it catches that as well. When you see this, that patient needs PCI emergently. Does that make sense?
Yes, sir.
All right, super. Now, and if you want to go ahead and jump in, go ahead. But the next thing I want to go to is the thing that's getting us all, that's tearing us all to pieces, right? And this is the Smith's modification. This is where Dr. Smith had to step in and say, this is broken. It's ruining the whole thing. Sgarbossa, it's a set of 3, right? Any one of these is fine. But if any one of them is unreliable, it ruins the whole criteria. And this is what ruins Sgarbossa for so many people physicians, paramedics, nurses, lions and tigers and bears, oh my, this is what got us. Okay. I'm going to show you why here in just a second. So this ST segment elevation in the center here looks profound, right? If you pull this off of a narrow complex EKG in a normal person with no left bundle branch block, and you saw this amount of elevation in the anterior leads, you would be concerned, right? Because that means there's a giant left anterior descending MI. It concerns me because what do they call the left anterior descending when it's blocked, Charlie?
Left anterior descending, that's the widowmaker.
Yes, they call it the widowmaker, right? There's a reason for that, okay?
Right.
And that's, you're talking about, there's three main coronary arteries that wrap around the heart. It's a screen's not messing me up here. And you're talking about the one that runs down the center that, depending on the person, it can perfuse part of the right ventricle, of course, the septal wall, part of the left ventricle. There's a lot of real estate there and a lot of functionality that is impeded when the left anterior descending is blocked, aka the widowmaker. So this was crucial for us to be able to identify because it's such a big deal. And this was the one that was unreliable. The reason is it's normal to see quite a bit of ST segment elevation in V1, V2, V3, and so on with a left bundle branch block, because remember, this is supposed to be discordant. The QRS complex is supposed to go one way, and the T wave is supposed to go the opposite way of it when you have a left bundle branch block. And at some point, those two things where they diverge, it may appear to be ST segment elevation. And what really gets us is when you see an anterior MI, this right here in the center, this is the kind of elevation, right? So it's almost a true imposter, although you guys know how I feel about it, the word imposter, okay? So let me bring it back up. What did Smith modify this with? So the old criteria was if you had greater than 5 millimeters of elevation here, that was indicative that there was an MI, but that's not the case. All right. And remember that your elevation, your height of your QRS, all that stuff can change just with the strain on the patient's heart. You can stop taking your blood pressure medicine for a few days and watch your QRS get larger and larger. Why? Because there's more energy going through the heart, right? Because the pressure is higher. There's more contraction. There's more electricity. There's more dromotropy going on. So what they found was there was a modification you could put that would rule that out. And what it basically boils down to is called an STS ratio. Now, I could spend 30 minutes explaining that nomenclature, but I'm not going to, because that's another piece of nomenclature that messes us up. Basically, what it means is if the ST segment elevation, when you see this, if it is greater than 25% of the total height of the QRS, that is indicative of an MI. So this has to be 1/4 or greater the total height or depth, as it were, of the whole QRS complex from the isoelectric line down. And if it is greater than that 25%, that is a positive Smith's modification with Sgarbossa. Now, what are the odds that your decision is going to hinge on this? This is what gets people. Here's what the odds are. How often do you see an isolated anterior MI all by itself? Almost never.
Rarely.
Yeah, rarely. Why is that? Let me show you why. Because there's three main coronary arteries, but they only come off of two holes in the aorta, right? Those holes are called ostia. Anybody who plays Scrabble tonight will be able to appreciate that. And I should have pulled this up earlier, but it won't take long. Coronary artery. So the aorta obviously has the highest blood pressure. It's the starting point for where blood's going to go in the body. It has two holes. So on the right side, it gives way to the right coronary artery, right? Obviously. On the left side, there's one big pipe coming off of the aorta. That one big pipe is called the left main coronary artery. And that one big pipe, the LMCA, is going to split into the left anterior descending and the left circumflex. So one pipe becomes two. Now, for this reason, it is very rare to see blood flow impeded in this entire vascular system in only a couple of leads, V1, V2, V3, right? That's why we don't see the isolated anterior MI all that often, because if you affect one part of a system, especially fluid-based where the pressures and things change, it affects the majority of that system. So when we see anterior MIs, when we see anteroseptal MIs, it is very common to see high lateral MIs to go with it because, and for anyone who doesn't know, this part of the heart I'm circling here where the left circumflex is, that's your 1 and AVL representative leads. And then this part here, the widowmaker, the left anterior descending, that's your V1 through V3 at least. And there's usually a little argument about V5 and V6. Charlie and I can get into that later, right?
Sure.
So you rarely see the isolated anterior, but yet again, Sgarbossa Smith shows us that it can catch even the austere ones with this. So if your STS ratio, if your total ST segment elevation, let's have a look here. If your total ST segment elevation in these leads especially, right, is greater than 25%, it's indicative of an MI, right? So let's have a look at this particular case because it's what we've been looking at. Here comes V4. Let me move Charlie and myself out of the way. So here comes V4, right? And we see that we have considerable ST segment elevation, but I can't stress this enough. It's normal to have it, right? Normal to have it in this particular context. Is it 25% of the total height of this? So you got to break out your calipers and measure it, right? But if we'll look at V6, of course it is, right? And of course, V6 gets into the lateral leads, doesn't it? Okay. So let's have a look at, say, V3, where we don't, this is not a quarter of the total height of that QRS complex. Even though the QRS goes off the paper where we can't see it, that's not a total height of it. But if we look over here, V6, is that at least a quarter of the total height of this QRS from the isoelectric line down? Oh, yeah.
Yep.
We are. And the reason I use this for an example is we already knew that, didn't we?
Yep.
Because look at 1 and AVL. We already knew the lateral side of the heart was impacted, didn't we?
Yep.
So we can look at it from here and say, okay, we get why that rule works. Right. You know what I mean? And again, the only time you're going to make a decision as to whether or not to alert the cath lab on an STS ratio alone, without 1 and AVL, without anything else going on there, the only time you're going to do that is when you're dealing with an isolated anterior MI, which are exceedingly rare. So it's not that big of a deal. It's not like you have to cram this stuff in your brain and be terrified every time you use it. In point of fact, it's one, not that complicated, and two, has a tendency to follow all the same epidemiology rules that we already know, right? But what do those rules mean? It means that ST segment elevation going the same direction as the QRS complex is going to be indicative of a STEMI. And those other two criteria, like the ST segment depression in V1, V2, or V3, it would be very rare to see it by itself. So even if it was there, you're probably concentrating on 2, 3, and AVF because there's already an MI there. And if you do have to measure STS ratios and see if it's a quarter of the height of the QRS complex, that's probably happening in the presence of 1 in AVL. So you're probably noticing 1 in AVL and not all that. Very rarely would you be on the fence about those second two criteria 2 and criteria 3.
Right.
Most of the time, vast majority of the time, where do our STEMIs present? They present in either the high lateral or the inferior wall. That's where we see them, right? So that is easy to identify. It's going to be just as common as all the other STEMIs you're out there treating in the field. So those other two criteria, you do need to know them. You do need to look for them. But should you let that stress you out because it's some austere thing that you've got to remember? No, don't let it stress you. This STEMI is going to follow the same rules as the other STEMIs that you treat. There's no reason to be intimidated by this thing.
Yeah, that's awesome. That's the breakdown is good, and I'm going to steal the screen again.
Sure. Yeah.
Oh, good deal. Okay.
From the ST segment depression.
There's just another example, exactly what we just talked about. This is in ECG Hero, and we go over this, which we were talking about things like, let's throw one of these in there and see if people dig this. In the end, he's right. It's very easy. It's concordance, both hands up, QRS, ST segment elevation, both hands down. That meets it. And then, of course, like he just went over pretty well, if that STE, if that blue box is 25% or bigger than that S wave, which is in red, right? So the thought process, being able to apply that is all you got to do. And it's hitting like these, each lead is looking at that one section of heart, and you can begin to look and see where this is affected. And so that was pretty good. We talked about the reliability, and we did hit that right early on, the reliability.
Yes, it's worth saying again, powerful. 8 out of 10 times. If they're having it, 8 out of 10 times, it's going to show it. 99 times out of 100, if they're not having it, it's going to be absent. That's what sensitivity and specificity means. Sensitivity is the true positive. Specificity is the true negative. So when you say a sensitivity of 80% and a specificity of 99%, that means 80 times out of 100, if they're having an MI with their left bundle branch block, they are going to show this.
Right.
And 99% of the time, if they're having an MI with a side of left bundle branch block, or 99% of the time, if they're not having an MI with a side of left bundle branch block, it's not going to show it. That means it's incredibly reliable, one, to detect it, and two, to rule it out.
Yeah, perfect. That's good. All right, we've covered the reliability, how to identify it, the Sgarbossa versus Sgarbossa Smith modified criteria, and all this you'll be able to, if you're just chilling out, you're just listening, great. If you want to get a CE for this, then head over to em-unplugged.com and go about halfway down the page. Actually, I'll show you right here, I believe. Shameless plug here.
I do it, bro. People have been asking for CEs. That's the whole reason we put in all this, is they were asked. This is built out of requests.
Yep.
You know what I mean?
These are our podcast CEs, or our PCEs, and we're building a library currently, this included. So if you enjoyed this little lecture in a little bit, then that's awesome. If you want to go a little further and get a CE for it, they're between the $3 and $5 mark, and we're figuring out price points and all that as the day that we're recording this. So we'll put this up here next, and hopefully you guys will give it a shot. We will eventually have bundles and that kind of stuff for registry and IBSC and ASNA and various states down the road. But in the end, let us know what you think. If you want to give it a shot, that's awesome. Otherwise, I've enjoyed this. This is always a good topic. Cardiology is one of my favorites.
Yeah.
Obviously, it's Shade Tree's one of his favorites. I'll let you have the last word, but everybody, thanks for joining us, and I hope this helped. Shade Tree, you want to take us out here?
I appreciate it, man. I could talk cardiology for days. There's a reason I didn't name it Shade Tree Nephrology. You know what I mean? But guys, thanks so much for your time. Thanks for taking a look. If you want to get CEs for this, please do. It is something that helps us to support the channel. And the reason we want it supported is, just like you guys, we see the deficit in a lot of the Con Ed. We want to change the way education is approached. And at this point, we need EM Unplugged to support itself. So as long as we get an adequate return on our investment, the money that we invest building these platforms, building the website, the time that we put in, we'll continue to be able to just recycle that into more and more Con Ed and keep this thing going. So we definitely appreciate your support on this. It's not a drive for money. We're not buying boats. We're trying to do some good in the world. And that's the reason our CEUs aren't $400 a piece like a lot of the other guys. Yeah, it's hyperbole, but still, it's the reason we keep them in that price point, because you know what? We still work, right? So yeah, right. We're not movie stars with an unrealistic grasp of money. We're still working. We're still making what you're making, so we get it. That's right. Thank you for your time, guys. I hope you got something out of it. Make sure to drop a comment and let us know what we could do better, what we did good, and share it with a friend that you think could use it. Every little bit of that helps.
Beautiful. Yep. Smash that like button and ring that bell. And everybody, thanks a lot. Stay safe, stay salty. And of course, our motto here at EM Unplugged is, of course, unplug, get better, save lives.
And get out there and practice.
There you go. Take care, everybody. See you.
Bye.
Hey, everyone. Thanks for joining us for the EM Unplugged podcast. Be sure to like, follow, and subscribe for more.